Good evening, ladies and gentlemen, and welcome to our Eating Disorder Hope webinar presentation on how to be your teen's ally in eating disorder recovery, featuring our special guest this evening, Dr. Judith Brisman. And before we get started, I'd just like to point out a couple quick things. We will be having a Q&A period following Dr. Brisman's presentation, where you will have the opportunity to present or ask any questions that you may have on her presentation. You can submit your questions via the questions pane of your control panel at any point of her presentation. I will be collecting those questions and reading them to her during our Q&A period. Now, to do just a brief introduction on our featured guest, Dr. Judith Brisman was the founding director of the Eating Disorder Resource Center for over 35 years. She is the co-author of the book Surviving an Eating Disorder: Strategies for Family and Friends. She's also an associate editor of Contemporary Psychoanalysis and is on the editorial board of the Journal for Eating Disorders. She's a member of the teaching faculty of the William Alanson White Institute and also maintains her private practice in New York City. And Dr. Brisman also has 19-year-old twin daughters, so she is very familiar with this topic, which we are happy to be presenting to you this evening. So without further ado, I'd like to turn this over to Dr. Judith Brisman.
Thanks, Crystal. And I really appreciate your having me on tonight. What I want to do is really to talk about to both parents and professionals out there in terms of what we can do to support and pave the way to recovery if someone's struggling with an eating disorder. And just to clarify, in case my kids are listening, I don't want to imply my kids were eating disordered. They weren't, but they were teenagers, and being a parent of a teen is probably one of the most challenging things I've ever done. So I take both my training at my institutes, but my training from my kids to talk to you tonight. And I want to start by talking, what you'll get from me is that when someone's struggling with an eating disorder, there's an urgency to come in and deal with the symptom immediately. But at the same time, we're always questioning, well, why is that symptom there? What's the problem? And how can this be an opportunity to understand more about who the person is and what they're needing at this stage of their life? And I'll talk a little bit about the treatment of bulimia, binge eating disorders, and I'll also compare that to the treatment of anorexia, which is very different, because one of the things I want to really say right from the start is if someone is anorexic, as parents and professionals, there's a lot of things we can do to help that kid get medically stable and gain weight. If someone is a binge eater or bulimic, there's many things we can do to have them begin to question what they're doing and change their behavior, but there's very little we can do to make them lose weight or stop throwing up. And that's a really important distinction, and it lends very different directions in terms of what you do when you have somebody in the room or when you're the parent of someone who's struggling. So let me start with what normal adolescence is, because this is really important. Take a hard look. This is normality. What happens in teenage years is the brain goes crazy. The prefrontal cortex, which is the rational part of the mind, hasn't really developed yet. It's actually quite small until the age of 28. And meanwhile, all the synapses, which is like the wiring in the brain, are growing, changing. It's sort of like an electrical system where the wires are all going crazy. And the pleasure center in the adolescent's brain is exaggerated, it's big. And so what that means is that in normal adolescence, your emotional chaos is totally predictable. What you're going to get is hyper-awareness, stimulation, impulsivity. This is normal. Because what you want, think about this. I mean, we're living thousands of years after what teenagers were years, hundreds of years, what teenagers were years ago. But really, teenagers need to be risk takers because they need to leave their families. They need to get out in the world. Years ago, they needed to be out there fighting wars, fighting animals, crossing seas. You can't do that if you have a mature brain. The only way people can get out into the world during these years is to have a brain that's sort of on fire. And that's normal. So what you're wanting in teenage years is chaos. You're wanting identity confusion. What happens with kids is they identify with many different heroes and role models and cultural icons. You want them to dare to take risks and separate from their parents or caretakers. You want them to get to know their body sexually. You want them to experiment with what their sexuality is, their gender is, their friendships, their romantic partners. And in order to do this, it also means that teens need to have secrets. So for any of the parents sitting out there, I've lived through this. This is why I want to say that I know what it's like to be the mom of teens. It's scary times, both for the kids and for the parents. What happens, though, and I always wonder about this with anorexia in particular, maybe even with the other eating disorders or other symptoms, is what happens when things go well. Let me start with this. And one of my daughters helped me with this PowerPoint, and I noted to her that it looks like when things go well, people have white teeth. But in addition to that, ideally over the years, an identity starts to come together. You realize you don't really want to be a rock star, an actress, maybe, because maybe that's just going to be too unrealistic. Maybe you'll go to college instead. You begin to think about how you're going to soothe yourself. So teenagers who develop normally, they learn to write in journals, they play guitar, they talk to their friends. And out there as professionals and parents, we might want to ask, well, how do we soothe ourselves? Where is food used to soothe ourselves? Where's in the family? I always ask, what are ways of soothing oneself? When things go well, people find friends, romantic partners. They get a sense of their own sexuality and their own identity. And they begin, and ideally, and listen, we all work on this until late adulthood, but ideally, people learn how to communicate feelings and have a sense of privacy and boundaries. What happens for kids who get stuck and scared is they turn to the culture to tell them who to be. And this is called having a foreclosed identity. So they'll latch onto one's thing, and just to harken backwards for a second, they could be, some tattooed person that guy, that may be his identity. And if he locks into that and that's all he experiments with, it's possible he may close himself off from the rest of the world somehow, or the rest of possibilities of who he is. With kids who become eating disordered, they get scared of the chaos of adolescence. It's one of the things that happens. They don't even know they're getting scared of it, but there's changes in their bodies, there's changes in relationships, and they look to the culture to figure out how to be. And I had a 13-year-old kid come in who was anorexic and say to me, I've always been such a good person. I get straight A's. I know what to do. And I'm trying to be good. I just don't know how to be good around food. And I look at every single book, and every single book tells me that to be good, I need to do something else. And she was crying. She really didn't know what it meant to be good, but she was looking to the outside culture, to the scale, to the Victoria's Secret models to tell her how to be and how to look. And so when our kids get stuck, they get stuck because they hang on to an identity from the outside that's going to get them through. They rely on fixed, idealized notions of who they should be. They should be that Victoria's Secret model. And like I say, the identity is foreclosed, it's shut down. And this has really important implications. go back there for a second. It has important implications if you're a parent or a clinician, because what happens, or any sort of professional, because what happens when a kid gets stuck with food, everybody focuses on the food. And in a weird way, you start to get focused on this one part of the person, which plays right into the problem, which is that it has become their identity. And here I look to Erik Erikson, an old-timer psychologist, who talked about that the point of adolescent relationships and love, he says it's an attempt to define one's identity by projecting diffused self-images onto other people and seeing it reflected back to them. So you go out into the world, and for example, I had a really sassy little 14-year-old, and she was getting into fights with all her friends, and everybody was sort of distancing her. And she had to get feedback. She got it from her sister, actually, that when she's scared or anxious, she gets really annoying and sassy. And so it helped her have a sense of who she was. But what happens when someone becomes eating disordered is they get really shut down. They focus on their body, and what they want reflected back to them is how their body looks. So I have kids and teenagers and young adults telling me all the time, they'll walk into a party, they'll walk into a room of other people, and they want to know what their stomach looks like. Is their stomach flat? Is their stomach sticking out? Are their thighs fat? And what gets missed is someone reflecting back to them who they are. And I'll have patients who'll say to me, well, I feel fat, so, no one's talking to me. And I'll say, well, are you watching what your eyes are doing? What are your eyes doing, not your stomach? Because maybe your eyes are diverting eye contact. Maybe you're not getting people to talk to you because you're coming in so self-conscious. And what this means with parents, it's really important with parents, because when a kid gets in trouble with something, whether it's food or anything, really, it's so easy to keep reflecting back to the kid what they should or shouldn't do about that issue. Now, hear me out. There's no question we have to focus on the food and the body weight and the issues around the eating disorder, because that can be really critical, and it often is critical. But what I want, if there's anything you get out of this talk tonight, I want you to remember that no matter how bad it is for these kids, they're also going through their teenage years. And what you want reflected back to them are other parts of them. What are the parts that are funny or silly or responsible or resourceful or interesting? Many of these kids have stopped being interesting because they're just trying so hard to do what's needed of them on the outside. So what we're trying to do, the way I try to see this, and I talk to families about this, is the way I see people is I think we're all like a kaleidoscope, like we all have our own sets of beads. And in an ideal world, we all can shift those beads around and around, and you can see these brilliant colors. And as we all know from looking at kaleidoscopes, the pictures can change. So you can have one experience in one situation, you can be one person in another situation. But what happens when someone is stuck in an eating disorder is they get stuck in one particular part, and they don't go through the identity crisis that is needed in adolescence, because they're scared of dealing with feelings, they're scared of so many things. So what I often tell parents is, what do you guys, particularly when someone's stuck in an eating disorder, now there's all sorts of work focused on the food, but what else do you guys talk about at dinner? I once had a family, and I said, there was so much talk about food, and one of the kids was in recovery, out of a residential program at a recovered weight, but there was still talk about maintenance and what she needed to do to eat and what everybody was eating and whether it was healthy or not. And I said, well, who asks Dad what his day was like. And they all started to laugh. I mean, no one asked Dad what his day was like. And so it was really important for us to look at what parts of each of the person were missed, what parts of Dad were missed because he was being the authoritative person in the family and setting the rules, and what part of Mom was missed because she was the one that was always scared and feeling what the kids were going through. I mean, maybe she was stronger, maybe Dad was more feeling, but were those other parts of the parents missed? Just in the way that with someone who's eating disorder, many parts of the kid can get missed. So what our goal is, let your daughter put this up, the goal is an identity crisis. You want there to be many different parts of this kid that can start to emerge. And what you really want is a situation where someone doesn't really know who they are, because that's the first step with an eating disorder is if someone's identifying themselves as eating disordered or anorexic or the thinnest or the heaviest. We want them to have a certain sense of, well, who else are they? And how do we shake that up? So I'm going to talk a little bit about how we shake that up in treatment, what parents should look for in treatment, but also where parents need to be in terms of treatment. And I want to start in terms of work with kids who are either bulimic or binge eating, because as I said, the treatment for anorexia actually is quite different. But really, and actually this would be the same for anorexia too, really what you want is to create a sense of anxiety. Because if an eating disorder is in the picture, if someone is binging or throwing up or exercising or restricting, that behavior comes in every time someone feels anxious. And in a funny way, it covers up what potentially could be an opportunity, because the whole point of anxiety is to say that something is wrong. My brother was just saying today, it's like being a canary in a coal mine. I mean, anxiety means something's wrong, and you should listen to it, because only by listening to it can you actually come up with some solutions. You're either lonely, or you're scared, or you're angry. There's something that you want to do. But if someone's eating disordered, you're not going to be able to allow for that anxiety and that questioning unless we deal directly with the symptoms. And here's where it gets tricky. So as a clinician, what we're trying to do is to find a way to stop the symptomatology long enough so someone can become curious about themselves. As a parent, you have the same sort of role. So say you have a kid who's going to the cupboards all the time. You're concerned about not just her weight, because I think the weight is secondary. The question really is she using food to hide out, to deal with feelings. You feel that she's binging. The question is how you can not stop her from eating, but stop her long enough to be curious about what happens when she goes to the cupboards. How do you start a dialogue about who is she? What's happening for her? If she didn't eat, what else would she need at those times? How else could you be there for her? And you start to question why the behavior has been needed. So there has to be a focus, like I say, both on the behavioral intervention with the symptom, but trying to understand who the person is. And that's a really hard role, both as a parent and as a clinician. So what you need to know, I learned this years ago. My first training was in St. Vincent's Hospital here in New York in the alcoholism division. And I was working as a young 28-year-old grad student in a group with recovered anorexics recovered alcoholics who were the co-leaders, and also people who were drinking. And I remember talking to one of the young men in the group who was talking about his relationship with his mother, and I was a grad student, and I thought this was incredibly exciting. He was getting to the real issues. He was talking about his mother and how his mother was so hurtful to him. And I left the group ended, and I said to my co-leader, a recovered alcoholic, and I said, that was such a great group. We got to the real issues. And he looked at me and he laughed. He said, the real issue is that that guy is thinking about whether he wants to drink or not. And I say this because what our patients, what our kids who are eating disordered are thinking about is food. They're not thinking about, well, the real issue is I'm mad at my mother and that's why I'm restricting, or they're not thinking that they're feeling insecure. They're posting pictures on Instagram. They're measuring their wrists. They're measuring their thighs. They're looking at Victoria's Secret models to figure out who they should be. So how do you talk that language and introduce the language of the therapist, or the language of, who is that real person? This is a hard balance. And early, when therapists were starting to work with eating disorders, the first thinking was that if you interpreted what the person was really worried about, or really concerned or conflicted about, the symptomatic behavior would go away. So if the person was conflicted about expressing anger, and you talked about that and explored it, literally the need to binge, or the need to purge, or the need to restrict would stop. But years ago, Hilda Brooke, who was a psychologist, came on. She said, that's crazy. She said, just like this, these kids aren't thinking about the real issues. These kids this is what's on their mind. And for you to tell them that they're really worried about something else is really basically saying, I'm your parent and I know better than you what you feel. And this is really problematic, both as a therapist and as a parent. Because as a parent and therapist, how do we be curious about what's really happening to these kids? So what I say to the way I would work, and I'll translate that into what you do as a parent in a minute, is when I come in with someone who's bulimic or binge eating or purging or exercising too much, I want to start with the language of the eating disorder. I want to know everything about it. But I want to find a way in talking about it that I also know what it means to the person. And one of the first things I think about is, if you weren't thinking about food or your weight, what would be on your mind? And what I'm trying to do is to understand who the person is that's either binging, purging, restricting, going to the cupboards. Because what happens, this is like the kaleidoscope image, is that it's very easy for people to focus on the eating and not have any sense of who they would be without the eating disorder. And I hearken to Jenny Schafer's amazing book, Life Without Ed, because really what happens with an eating disorder is you start to know, who is Ed? Who is this sort of abusive lover who keeps calling you and telling you should do things their way? And as an analyst, over time, I try to understand, well, who is that part of the person? And the way I'll want to do that is, when I'm working with someone who's coming in who's binging, purging, is I'll want to make a contract with them and to say one time, one night, before they're going to go to the food, before they're going to throw up, anything that they're willing to do, one time, what could they do instead? Now, this focuses on the behavior. This is a first step in trying to change the behavior. But it's also trying to say, what would life be without Ed? Who's the person? Who else is there? Who's the person who's going to the food, and who is being neglected in a funny way? So when I have a patient come in, I might have her say, all right, if she's throwing up every night, let's say, or if she's binging every day, I might say, one of those days that you're storing food in your room, candy in your room, and after school you come home and you eat it, what if one day You don't go, just be one day between our sessions, you don't go to the food. And we figure out what, if the food weren't there, who would you be? What are you thinking about? What are you feeling? If you don't even know, can you write in a journal? And if you don't know your feelings, can you draw what you're feeling? Like, what's it like to sit there and not go to the food? What's on your mind? You know, are you worried about homework? Are you worried about your boyfriend? Are you pissed at your parents? I want them first to locate anything they can know about themselves, to see if there's anything they can do about it. Can they speak to that person? Where are people? I want to know if there's nothing they can do. Sometimes they got a bad grade. There's just nothing that they can do. What do they do to soothe themselves? Well, the candy has soothed them. Well, what else could they do? Could they call somebody? Could they FaceTime someone? Could they take a walk, meditate, take a bath? I mean, for most of the people I work with, it's very hard to come up with something to soothe themselves that doesn't involve food. You know, if they're walking, they're reminded of their body. If they take a bath, they're reminded of their body. If they meditate, they're thinking about food. So the idea of what it means to soothe themselves is a long, complicated process. I also just talk sometimes about, like, if this kid is going to her room and she normally goes to food at that point when she comes home from school, what else could she do just to distract herself, forget what she really feels? And I talk to you as parents too, because for all of us, we have moments where we want to do something differently. And what are we going to do instead? We need to all take a look at our own behaviors to see how hard it is to change and what it would be like to ask our kids to change. And then sometimes when I'm saying to this kid who's coming home from school and binging on candy, well, what about food? Maybe you're hungry. So before you just eat the candy, can you give some thought? And this is where I often will work with a nutritionist in terms of, is somebody really hungry? What could they eat that would feel okay? And we try to make a contract between one session and the next of one thing the person would be willing to do instead. Now, as a parent, what's really important is I want you to start a dialogue with your kid. If you're concerned about where she's eating, if she's overeating, if she's anorexic, that's a different story. We'll talk about that in a second. But if she's binging, purging, you know, I've had parents who say, well, listen, I promise I'm going to give you $50 at the end of the week if you don't binge it all this week. You know, maybe for a week or two it'll stop the binging, but it won't get the person to be curious about who they are. And it won't get the person, you won't be parenting this kid who needs parenting to get through adolescence. So what the first step is you really just need to start to talk. You know, you're concerned, you don't know what to do, it makes you feel helpless, you find yourself yelling at her at these times. Is there anything else you guys can do? What does she want to do? The first step is to try to just communicate around it. If you get stuck and you're in a power struggle about what is being eaten, what's being thrown up, I mean, that's always when a professional help might come in just as a mediator, if nothing else, in terms of what to talk to the kid about, what she or he wants to do about the eating without the parent being in a control battle about it. And then I say to parents, what I'm doing with the behavioral contract, I'm not just trying to change the food. I'm trying to look at what they do with the contract. Because one of two things will happen. Either the kid will come back and say, hey, you know, Tuesday night I didn't binge at all. I didn't go to the food and I did everything. And I'm like, that's interesting. Are you always so compliant? Or sometimes I get this. Well, not this. No, this is not what I get. I'm looking for the person who's binging and starving. This is what I get sometimes. And that's interesting to me. If a kid comes in and says, this is ridiculous, this contract won't help, good. Tell me, who's this person who's so angry? Why are you so angry? What do you want to do? You know, you're saying to me, the hell with it, I'm not going to do what you want me to do. Well, what do you want to do? And that's what's very hard about teens, because they can get you into a control battle so easily if you're the parent or the therapist. I always tell my teens, it's like you're playing tug of war. Your parents have the rope, or I have the rope, and you have the rope. And we'll say, try not to throw up one night. And you'll say, the hell with you, no. And I'll say, all right, let's put down the rope. What do you want to do? And that's a hard dialogue to have with a teen when they're using food to cope. But the question would be, well, what do they want to do about it? What's one step? Certainly if I'm in therapy with somebody, that's where I'll be talking, and that's what I'll be speaking about. And so I'm constantly taking the next step of what's one more step they can do to change the behavior, whether it's binging or bulimia. And in addition, looking at, well, who is that part of them that's gotten foreclosed, that's gotten shut out, where there's been sort of a dissociation, so that no one gets to see the person who's binging. Sometimes my patients will say, well, it's like I have this crazy person in a cage. And she comes out when I come home from school. During the day at school, I'm perfect. I get straight A's. People like me. I have great friends. My life would be perfect if I could just get rid of this part of me. And I'm saying, no. We have to get to know that part of you. And who is that? Is she hurting? Is she angry? And parents, that's what I want you to be thinking about. Who's that part of your kid? Why, who's doing this? Of course, it brings into question, of course, if a kid has ongoing symptomatic behavior around food, do they need medication? That's always a question down the line. But for the moment, I want to just play with the idea of how we play with the behavior and how we play with helping someone get through the teenage years. Now I'm giving you a really cursory view of what to do, and I want time for questions and answers. But let me talk a little bit about the treatment of anorexia, which is very different. And I purposely have left this as a blank page because if you sit in the room and try to understand who that person is, if she's starving, you're going to get nowhere. And I was trained as a psychoanalyst, so when I started, no one was working with anorexics and bulimics when I started. We're talking over 35 years ago. Very few people in the country were there. And so I really believe that if I sat and talked with someone who was anorexic and we understood what she was feeling and where she was covering her feelings, what she was mad at, what she was scared about, that the need to starve would start to abate. And guess what? It didn't. And so over time, in the beginning, what we thought was, I'll jump forward, when we first wrote Surviving an Eating Disorder, we thought that if parents just disengaged from trying to control their kids, the kids would have a better sense of their own identity, and they would be able to figure out what they wanted to do about food. However, what we found over the years, the Maudsley researchers out in London began to say, wait a second, families are right in the trenches with these kids. They know more than anything. Why are we trying to get them out of the picture? And we actually should look to the parents as the first line of treatment for these kids who are anorexic. What can parents do to pave the way to recovery? And in our second book, we really this was the third edition actually, we focus on how the parents can get involved with both feeding their kids or setting the stage with a team for recovery with their kids. And let me talk a little bit about that. Because when you have a kid who's anorexic, like I said, I had someone come in years ago, and we were trying to get a sense of just what was going on for her. This was before we even knew that she was going to need intensive treatment, which she did. But I asked her what she was feeling, and she sat with her arms across her chest, and she didn't say anything. And so I thought I'd be creative, and I gave her a pencil and paper and said, well, why don't you show me what you're feeling? And she drew one straight line down. really angry and completely impossible to reach. Words were not going to reach her, and words aren't going to reach our anorexic patients. The first line of treatment is the message is medical stability. And getting the parents and the family involved so that they're right there in the trenches, either directly feeding their kids, or if that's too complicated, and often it is, then how can they work with the team so that the parents are in control again? What we want parents to be able to do is to be able to set limits with the team. I'm going to come back to this in a minute. What we want, if outward treatment is needed, you want the physician to be in there to establish a goal weight. You want a nutritionist to be there, a registered dietitian, to say, okay, this is what kinds of foods are needed in order to gain a pound a week. That's usually what I work with. The therapist is looking at what's getting in the way, where the kid's having a hard time, and usually in these team approaches, the therapist there has to be a leader in the team, somebody who's communicating with the team at every week, and also with the family. But the important piece is that the family is key. The family is there to establish with the team and with the patient that if weight isn't gained, what are the consequences? And so someone asked me yesterday, like, what's my sauce? What allows for change with anorexics? And I said, the first thing is leverage, and the second thing is giving them a voice and allowing them some sense of control. And how do you balance that in the treatment program? So the leverage is with the families. The message has to be, if a certain prescribed weight is not gained a week, the kid, if she's outpatient, is off the hockey team. She's off, she's not going on the spring break trip. She may need partial hospitalization as she goes to school. She may need to be taken out of school and get into a hospital. And the irony is that it may not be that the hospital is going to change the kid, but knowing that the parents are back in authority and setting the limits, and that this really is going to happen. I've seen so many kids be able to catch their breath and gain exactly the needed amount of weight each week. But the parents have to be really clear that this is going to happen, so that right from day one, you need to know what the partial hospitalization programs are, what the residential programs are, what the consequences of leaving, even if you're captain of the hockey team or the basketball team. I've been in that situation. And that the parents are brave enough and courageous enough to say, no, that if this kid can't eat in a way that's going to take care of herself and get herself healthy, that this really is going to happen. And whether a family needs to actually directly feed their kid, or whether they need a team to help them. There's a lot of support programs online for families, that if you're on your own or working just with a therapist or a physician in terms of trying to help your kid get healthier and maintain weight, get online, go to Feast, F-E-A-S-T, go on any of the family support programs so that you're not in it alone. But one of the things I want to say is sometimes parents have tried to feed their teenage kids, and the kid has still just like what the worst thing that a kid can say is, I don't care. Take away the trip. I don't care. And if it gets to that point, it means that the disease is so powerful. It means that professionals have to come in, and then if the son or daughter still can't gain weight, then of course it means residential program or hospitalization so that medical stabilization occurs. But what I want to say is there's a conflicting message out there that parents should be able to do this. And I've had parents come in and say to me, the whole point is that parents aren't supposed to be blamed for creating an eating disorder, which I totally agree with. But these parents will say, but you know how blamed I feel that I can't get my kid to eat? So I want to say this is all a balance, because sometimes it means that you really have to give some control to the kids. Sometimes it means it needs to take control away from the entire family and get some help in there, get some other people in there helping you. But the point that I want to say, because I want to open this up to questions in a minute, is take a look. This is normal adolescence. Here in New York City, by 9th grade, kids are drinking, kids are introduced to drugs, kids are introduced to sex. There's all sorts of unhealthy eating around. It's a chaotic, scary world. In fact, I had a family in tonight, and we were laughing because the daughter who's in recovery is now, she's certainly older than 9th grade, and I was saying, look, this is what happens in 9th grade. This is normal. And the family was laughing. They said, well, we missed that. You know, our kid was anorexic and in a hospital. And we all laughed because it was sort of like, well, you know, maybe she was smart. You know, she didn't have to brave that yet. In recovery, now she is. Now this is what the whole family has to deal with, is what choices and what limits are going to be set around drinking, smoking, drugs, sex, food. So the point I'm trying to say is that throughout, do we want to just focus on the treatment of the eating disorder? If we do, we miss that there's a whole piece of development that needs to be paid attention to that has to do with going through teenage years. And so this is the message that I want to give these kids that's obviously really poignant. I'm going to end by saying that if you're a parent out there, the most important thing you can do is to try to be curious about who your kid is and imagine all the different arenas he or she needs to grapple with, and to think, well, what are they grappling with? What aren't they? Talk to them about where they need your support. If they're struggling with food, see if they're willing to make a contract with you for a day or two, you know, around that. If they're binging, if they're anorexic, I was talking about how you can intervene directly. But the most important thing is both communicate, and if you need support, get support. These are daunting, difficult disorders. And so if and when you need help, know that you're not alone. There's a lot of people out there and a lot of support teams to guide you and your kids through. Okay, and in that note, I'll give you my information, but Crystal, I think we want to open it up to questions, thoughts. Can you hear me?
Yes, and thank you so much for your excellent presentation.
Oh, you're welcome. You're welcome. Yeah, it doesn't look like there's any questions there.
Yeah, well, we had a couple come in, and just as a reminder, if you are on with us still and you have any questions for Dr. Brisman, feel free to submit them through the questions pane of your control panel. Dr. Brisman, one of our attendees was wondering if you could speak to the issue of co-occurring disorders in teens, and if your treatment approach is still similar when there's substance abuse involved.
Yeah, you know, I actually feel usually you don't see anorexia in substance abuse. I mean, what I think about is what's most physically dangerous. So if there's substance abuse, I would deal with very differently than bulimia or binge eating. I mean, substance abuse, I would go in a crisis sort of way, want to intervene and want to make sure that there was a support or team or program that was working towards abstinence, if you're talking about substance abuse with a kid. And I would do that before I would focus on the eating disorder. But I would want to do it with a program or with professionals who were savvy that the eating disorder could be another drug, like overeating or binging and purging is just another way of dealing with feelings. But I always go in with trying to stabilize the substance abuse first. And what every single one of my patients will tell me is, give me drug or alcohol abuse. That's so much easier. I kicked that. That was fine. The food is the hardest thing of all. So that often takes a much longer time. Yeah. Does that make sense, Crystal?
Yes, thank you so much. Another attendee is wondering if you know or recommend any specific treatment centers that specialize in the Maudsley method.
Oh, that, here in New York City, the Mount Sinai program in New York City specializes in the Maudsley program, and there are many. I don't. If let me say this: if there's a program that doesn't actively involve the family, run, get away, don't be involved in it. I know eating disorder recovery. I'm sorry. Oh boy, yeah, in Denver, Eating Recovery Center in Denver, and they have facilities throughout the United States, actively involves a family. Actually, Oliver Pyatt does it. All sorts of centers do. In Montanito, they involve the family, but I think each family needs to be worked with individually to see how they best can affect change. So I'm not giving a great answer on that. I think the best bet would be to call different facilities, but here in New York City, Mount Sinai would be the place to go. What else? Any other questions, or if anybody disagrees with anything that I'm saying, I would want to hear that. I know a question that came up recently was, when I work with anorexics, we talk about someone gaining a pound a week, and that comes from a particular place. Usually when the patients come to me, they can stabilize within 10, 15 pounds. If someone's needing to gain 30, 40 pounds, the question is whether they need to be hospitalized, or if the parents are just working on their own to feed their kids, certainly more than a pound a week would be needed and is medically appropriate. But when you're working with the kids that I tend to see here on an outpatient basis in New York City, you're talking about fairly high functioning kids who are playing at low weights, 10, 15 pounds below what they should be. They can't stay at those weights. They're not healthy. Their hormone systems have shut down. Sometimes it's affecting their hearts. But what I'm trying to balance when I say a pound a week is also their sense of control, because what I worry about is kids going into treatment centers or being they're feeling that they're forced to eat, they gain the weight, and then they don't have any sense of control over themselves, which is such a huge part of a developing teen's experience, that they end up either losing the weight or throwing up. And I'm just really worried about kids gaining weight too quickly and not feeling in control of their body. So, I'm constantly juggling, like, this is what you need to do to be medically stable, and okay, can you catch your breath and feel like this is yours, and you don't want to be the kid walking down the street who everybody's looking at now and says is anorexic. Now, luckily, people don't want to be that kid, even though they may not be able to gain the weight. So it's a constant struggle between allowing a teenager that needed experience of being in control of their own body and getting them medically stable.
Mm-hmm. Thank you for sharing that.
Yeah.
We have a couple more questions that came up.
Sure.
One of our attendees said, "Thank you for your insight. My daughter just began a partial hospitalization for anorexia and self-harm. Ironically, several months ago, she confided in me with great concern about friends who are going through the very same issues, and now she's in treatment. Does this seem like modeling behavior?"
Oh, this is what's so hard about the culture. These kids share pictures of cutting on Instagram. By ninth grade, they're, all the self-harm kind of thing, you see pictures all the time with other kids. The question is, what kids end up feeling like that they need to, again, to focus on what other people in the culture are doing. to take care of them, to take care of their own needs, their own feelings. All right, let me back up with that, because the kids right now, this is actually really important for families to know. Kids right now are experimenting with self-harm, with bulimia, with laxatives, with throwing up, the same way they experiment with cigarettes and drugs and booze. And so in a funny way, as parents, we need to let kids know that, look, this is going to be around them. And how do you help a kid develop a sense of a sturdiness, so that even if they experiment with it, they're not going to, to do this repetitively to take care of themselves. That being said, I'm speaking to this particular mom. I'm answering, it's like, it's so hard to know why your kid fell into this. They're all going to be seeing this in the culture now. But the work I would want to focus on is not why that happened, but what you could do now to keep her strong, to keep her knowing she's still going to see this. And she's probably going to come back, and, can she be around different friends, or can she know that's there? And what does she have that she can feel good about that can be separate from that? It's one of the hard things about doing a live podcast is you can't see reactions, so I can't get a sense of whether that meets someone's question, whether it doesn't. So I'm open to any feedback.
Thank you so much. We appreciate it.
Yeah.
And another one of our attendees is wondering, if weight should not be talked about, how do we let them know if they're doing well or not?
And is that, I guess it would be the case if someone's gaining weight or losing weight. Boy, this is where I wish, someone could be there and I could have a dialogue, because when someone's gaining weight, I think it actually speaks to the question of what I'm saying. It's like, if you weren't focusing on weight, how would you know whether your kid was doing well or not? That would be the way I would think about it. What would you be talking about? How do we know whether these kids are doing well or not? And what are the other ways as parents that we can just talk? And sometimes as a parent, I'll speak from my own experience, it's very easy for kids not to see your own vulnerabilities. And so you're the parent directing the way, trying to do the right thing. Sometimes kids open up when you talk about your own history, or what's hard for you, or where you have a rough time, without overwhelming them, obviously. So that's one direction. But I think the question is, if you didn't have weight to gauge whether things were going well or not, how would you gauge it? Yeah, that's a question, Crystal. I'll leave open. I won't even answer.
Yeah, that's really great.
Yeah.
Thank you.
Yeah.
And I think, as a follow-up, our attendee is asking, the weight is what the doctor looks at to see if they're doing well with food.
Right. The only way, the reason for that, I have several situations right now, is that the doctor, the nutritionist, the whole team, and the parents, in fact, have to know about the weight, because what we see happen all the time with anorexia, and I'm assuming we're talking about anorexia here, is that kids will report doing really well. The parents will see them eat. We'll see them saying that they're adding oil to their meals. It looks like it's all going in the right direction. But when you don't see the kid, and we're talking about teenagers now, so there's going to be a lot of time at school, a lot of time when the parents aren't right there, or the team isn't there. The kids are exercising, they're restricting, they're taking, they're doing anything they can to lose the weight. So we have to look at the weight. I work this way too, because it's the only way to tell how hard the kid is struggling. We have situations where kids know they have to gain, a pound a week to stay out of the hospital, let's say, or stay out of partial hospitalization, and they water load right away. And what I say to the parents is, look, we're not going to solve this in a week or two. So they'll gain 2 or 3 pounds the first week, but if eventually we have to keep seeing the weight go up, and eventually they can't, the water loading will only take them so far. So we may lose a week or 2 in there, but if they're not, in a critical place, we use that to sort of even things out. We use the time. But I think what I want to say is it's really complicated, and every single case is different. But unfortunately, we do need the weight, and the kids don't need to see the weight. They can just know that they're going in a good direction, or that they need to eat more. But we really need that, or the disease of anorexia is so fierce that you need everything you can to fight it, and otherwise you're going to miss these kids. Yeah. Anything else, Crystal? Yeah, were there other?
Yeah, I think we have time for one more question, if that's okay.
Sure.
One of our attendees is asking, behavioral contract as a parent, should we involve our son's counselor? And she asks, our son likes to say, it's my counselor, I can talk about what I want to talk about. And then
Yeah.
she mentions, I think the counselor must include us in the sessions, otherwise it won't work. Thoughts?
Boy, it's a hard one, because I can't imagine seeing a teenager without having some involvement with the parents, even if it's to say, hey, listen, your kid is doing okay, and I'm going to contact you if there's anything else, and this is what, but I do think therapists should be able to speak to the parents and say, listen, this is what would help, and this is what wouldn't right now. So it's tricky, because I never quite know what I'm walking into when I say something like this, but I would want, maybe it's worth a phone call to the therapist to say, look, I just need to know what we should be doing, what we shouldn't, why. Is there anything that we should be doing to support our kid? And I don't think parents should be left out of the picture. So it's tricky, because I don't know the specifics of the situation. But if it's a teenager, and underage in particular, you have a right. And what I'd say to your kid is, look, we don't want to be on your back. We want to be able to know what we should do so that we won't be hurting you, so that we won't be nagging you. And that would be the goal in getting it in and just speaking, or finding out more what you should do.
Mm-hmm. Thank you,
Yeah.
Dr. Brisman. We really appreciate you taking the time to be here with us and share your insight and your expertise and this wonderful presentation. And again, to all our attendees who are with us, if you came in a little bit late, we will have a recording of Dr. Brisman's webinar available on eatingdisorderhope.com, where you can check that out. And that concludes our presentation for this evening. Thank you so much again, Dr. Brisman.
Thank you. And I just want to say that if anybody has questions or wants to be in contact with me, email is a great way to reach me, and I'll answer anything that comes in. So I thank everybody for listening.
Yes, thank you. And just to our attendees as well, if you want to check us out at eatingdisorderhope.com, we have our webinar scheduled there with information regarding all of our upcoming webinars. So we hope to see you on our next webinar presentation. And until then, have a wonderful evening.
And thanks, Crystal. I really appreciate being on.
Thank you, Dr. Brisman. Take care. Good night, everyone.
Bye-bye.